management along with my team, Dr. Kanimuri, Dr. Vivareshma, staff nurse Janani and staff nurse Angel. Okay, thank you. Live to delivered an alive girl baby of weight 3.8 kg. Now the time is date is 16/10/2025. The mother delivered at 2 p.m. Okay, so now the mother is in third stage of labor after delivery of the baby to delivery of the placenta. Now she is in her third stage of labor. Now we are going to perform active management of third stage of labor to prevent for the prevention of postpartum hemorrhage. Third stage of labor. Now, Dr. Kanimuri, please give injection oxytocin 10 units IM. Take it from the refrigerator. So we have to maintain efficacy. It has to be stored between 2 to 8 degrees Celsius. Take it from the refrigerator and give 10 units oxytocin intramuscular. Okay.
Injection oxytocin 10 units IM given, ma'am.
Now, after ruling out the presence of another baby, I am separating the placenta and membranes by giving controlled contraction. Okay. So give counter traction above the pubic symphysis and give controlled contraction to deliver the placenta. Once the placenta and membranes are at the vaginal outlet, you have to rotate the placenta and membranes to complete it in total. Okay. Now after removal of the placenta and membranes, we have to check the placenta and cord for the completeness. Okay. I have to check whether it is a 2-vessel cord or 3-vessel cord. Now it is 3-vessel cord. And I have to check whether the cotyledons are fit together. Now I have to hold the placenta like this in an inverted condition to verify all the membranes are completely removed. Okay. Now I am disposing the placenta in the yellow bin. Okay. Now the third step of Amstell's uterine massage. So we are now in the fourth stage of labor. It is the immediate postpartum period, 2 hours later delivery. Okay. Now you have to massage the uterus. Now the time. கொஞ்சம் வலி இருக்கும் பொறுத்துக்கோங்க
வலிக்குதுமா
சரி கொஞ்சம் பொறுத்துக்கோங்க கர்ப்பப்பை சுருங்கணும்னா நல்லா மசாஜ் பண்ணாதான் சுருங்கும் கொஞ்சம் நீங்க பொறுத்துக்கோங்க சரியா
சரிம்மா நான் பார்த்து பண்ணுங்கம்மா
Now the time is 2:15 p.m. Now I feel that the uterus is flabby, the tone is not good and the patient is bleeding heavily. Since it is an obstetric emergency, I have to call for help. Please Dr. Kanimuri, call anesthetist, staff nurse, staff bring the PPH tray. Dr. Vivareshma, Dr. Janani, please come. Now I am assigning one person to the head end. Okay, Dr. Vivareshma will be at the head end. Head end person will monitor the patient's condition. She will give reassurance and she will record the vitals, which will be done by the arm end person. She has to check the saturation levels and she has to start her on oxygen. Okay, then the arm end person I have assigned Dr. Kanimuri and staff nurse Janani at the arm end, and the arm end person will do IV fluid management, then medical management. Okay. Now the patient is bleeding heavily. Dr. Vivareshma, check the condition of the patient. Tell me the vitals.
Yes, ma'am. Ma'am, the time is 2:50 and the vitals of the patient is temperature normal, BP is 110/70, pulse is 80 and the patient general condition is fair, ma'am.
Reassure the patient.
மா பயப்படாதீங்க ஒன்றும் இல்லை உதிரப்போக்கு கொஞ்சம் அதிகமாக இருக்குது டாக்டர்ஸ்லாம் செக் பண்ணிட்டு இருக்காங்க
Dr. Kanimuri, secure 2 IV lines, large for IV cannulas.
Sir, 2 18 gauge IV lines are secured, ma'am, and I have taken the samples for CBC, RFT, LFT, coagulation profile and I have seen the BTCT, ma'am. I have connected 2 RLs, I'm rushing it over 15 minutes, ma'am.
NS on the another line. Janani staff, please start injection oxytocin 20 units in 1 RL at 40 drops per minute for managing the PPH. So initial is IV infusion, start 20 units in 1 RL at 40 drops per minute. Okay. The injection oxytocin started, the patient is still bleeding, but so staff please call the blood bank and reserve adequate blood.
The blood bank staff I have called.
So mother is A positive mother. If the A positive blood is not available, ask the blood bank team to be prepared with O negative blood. Okay. Dr. Janani, please inform the attenders. talk to the attendants. Please inform.
Yes, ma'am, I will inform.
Now,
டாக்டர் லைட்டாக ப்ளீட் ஆகுதுமா, கவலைப்படாதீங்க, டாக்டர் பார்த்துட்டு இருக்காங்க, சரியா? பதட்டப்படாமல் இருங்க.
the bleeding has not controlled. Dr. Kanimudi, please give injection Corboprust 250 microgram IM. Ask the patient whether she has any history of asthma.
உங்களுக்கு ஆஸ்மா தொந்தரவு எதுவும் இருக்குங்களா?
அதெல்லாம் எதுவும் இல்லைம்மா, எனக்கு இது வரைக்கும் எந்த பிரச்சனையும் இல்லைம்மா.
Ma'am, I'm giving injection Corboprust 250 microgram IM, ma'am.
Now, the medical management has been completed, but the bleeding is not getting stopped. So, I am moving on to the mechanical methods of management. Okay.
Ma'am, the time is 2:30 now and the vitals are 109, the pulse is 109 and the BP is 128/81, ma'am. The patient general condition is now fair only, ma'am.
Okay. Now, I am doing bimanual compression of the uterus. Now, I am inserting my right hand inside the vagina and I am keeping it over the anterior fornix between the cervico-vaginal junction, anterior fornix, and I am placing my left hand behind the uterus. Now, just I am compressing the uterus. I am antiverting the uterus. The mechanism is here. The uterine artery will be running like this. Here. The uterine artery will be running here. So, when you compress the uterus, when you antivert the uterine artery will get kinked and the cervical branches will also do not get blood supply. So, the bleeding will be arrested. The spiral artery lumens will be occluded and the bleeding will be arrested. So, the bimanual compression can be given for 10 minutes. An assistant to assist you. Okay. Once you feel that. So, the bleeding is not getting controlled in spite of bimanual compression. Now, I am asking my assistant to give aortic compression. The Kanimudi, please stand on the left side of the patient. You keep your heel of your right hand above and lateral to the umbilicus and give compression. And feel for the femoral pulsation and give compression for 20 seconds. Feel for the femoral pulsation. If you feel the femoral pulsation, the compression is not adequate. So give compression for 20 minutes and relax for 20 seconds. 20 seconds and relax for 20 seconds so that the patient will get blood supply for lower limbs.
மூச்சு வாங்குற மாதிரி இருக்குமா லேசா?
கொஞ்சம் பயப்படாதீங்க. Dr. Ivareshma, check the vitals and inform.
Ma'am, the time is 2:40 now and the BP is 90/60 and the pulse is 110, ma'am. The patient is feeling like giddiness, ma'am.
Uterine. So now I am moving on to the next line of management, that is uterine balloon tamponade. Just I will give a demo. So this is the ESN, that is every second matters uterine balloon tamponade. ESN UBT. Okay. So now for the demonstration purpose, I am using this water bottle as a UBOTS and it has a inflatable balloon here and there's a condom ring. So it has rings to stabilize the condom. So you have to spread the condom like this and it's insert the balloon catheter inside the condom. Just half the way and fix the condom with this ring. Okay. The catheter tip will have a balloon, inflatable balloon. Now, I am inflating the balloon which is inside the condom. Okay, to fix it inside the cervix to avoid slippage of the catheter from the uterus. Okay, now I have just inflated the balloon with just 15 ml. Now, imagine this is the uterus and this is the cervix. Now, I am placing my hand inside the vagina and I am fixing my hands below the cervix and I am sliding this catheter over my hand inside the uterine cavity. Now I have placed the catheter inside the uterine cavity. Okay, now this is the another port to infuse saline to fill the condom balloon here. So we can give up to 200 to 300 ml of saline. The syringe has to be fixed by turning it like this. So after fixing it, you have to fill the condom balloon with the saline. Shape of the uterus. Thereby it occludes the all anterior wall, posterior wall and lateral wall. It gives uniform compression over all the walls of the uterus. Thereby it stops the bleeding. Okay. This is the ESM UBT, every second mantis uterine balloon tampering. Okay. Once the bleeding gets stopped, you can have the balloon in situ for at least 6 hours. Okay. Now the bleeding is not getting controlled, so we are moving on to the next line of management. Ureshma, the time is 2:40 now. Tell me the vitals and general condition of the patient. The patient is still bleeding, so call the anesthetist.
Ma'am, the time is 2:35 now and the patient is irritable. The BP is 90/60 and the pulse is 130, ma'am.
Sir, anesthesia, sir. This is PG from OG, sir. There is an emergency PPH, sir.
Suction and retraction cannula. This SR cannula is a recent advance in the management of PPH. Okay, so we are using it with the vacuum assisted devices. So by creating negative pressure, it has many fenestrations in the upper end. Okay, so it has a connection tube here.
Meantime, anesthesia assistant professor sir asked him, since patient is losing blood and feeling dizzy and breathless, we have kept oxygen mask as first line management. 10 liters of oxygen.
மேடம் மா பேர் சொல்லுங்க.
ஜனனி சார்.
நாக்கு என்ன எங்க இருக்கீங்க தெரியுதா?
சார் எனக்கு வெள்ளையா என்னவோ தெரியுது சார், எனக்கு ஒன்றும் புரியல.
சரி இருங்க. மேடம் பேஷண்ட் Madam, patient feels irritable. Vitals also heaving unstable.
So I am inserting the SR cannula. After retracting the posterior vaginal wall with the speculum. So after depressing the posterior vaginal wall with the speculum, I have to catch hold of the anterior lip of cervix. Now I am inserting the SR cannula inside the uterus. Okay. So I am feeling it from the abdomen. So it has entered up to the fundus of the uterus. Now I am connecting this connector to the vacuum apparatus. You have to raise the vacuum pressure up to 600 millimeter of mercury. Okay. Stop, connect it to the vacuum apparatus and raise the pressure up to 600 mmHg. Now we have to check for the bleeding again, the help of the speculum. So if the bleeding gets arrested, we have to hold the tube in place. So the vacuum apparatus should be turned on for at least 20 to 30 minutes. After 20 to 30 minutes, we have to clamp the pipe and then disconnect the pipe from the vacuum apparatus. So allow the SR cannula to be in situ for at least 6 hours. So if there is no no bleeding after that, we can safely remove the SR cannula. But in this patient, the bleeding is not getting controlled. So, sir, what's the condition of the patient now?
As an anesthetist, I'm assessing the patient. Patient feels very irritable, also not responding properly. Pulse also feel feeble. So my vitals also hemodynamically unstable. So the patient needs emergency intubation. Shall I proceed?
Yes, sir.
Okay.
Dr. Yoreshma, go and explain the attenders and get informed consent from the attenders. Dr. Kanimudi, please inform blood bank that the patient is deteriorating, so we need more amount of blood. Okay.
So now I am deoxygenating this patient with mask and ambu bag and with oxygen. Okay. And meantime, I am asking any other attendant. Line இன்னொரு line secure பண்ணிட்டீங்களா? ஒரு line தான் இருக்கா? இன்னொரு line secure. Put another line with 18 gauge needle and rush the fluid. Okay. Start this drop support injection or adrenaline double strength. Okay. Initially start is at least 500 ml NS. You can connect it to later to infusion pump. Okay. Just start immediately, quickly. Okay.
So the patient is started on inotropes in view of deteriorating vitals.
Yes. Because of saturation also falling, I am pre-oxygenating the patient now and asking my attender to give this anesthesia drugs for as a muscle relaxant injection succinylcholine initially 100 mg IV. Give the drugs immediately. I am going to intubate the patient.
So the patient is actually
Still bleeding. So also patient also conditions also deteriorating. Okay, vitals is as the patient is hemodynamically stable. I will need to put this emergency intubation. Okay.
So I'm giving the intubation drugs. I'm sedating the patient. Muscle relaxants, succinylcholine has been given. With the record pressure, rapid sequence induction has been done. Sir has intubated the patient. Bilateral air entry is now checked. So we can visualize bilateral chest rise and it's equal. So now I'm securing the tube with the plasters.
So after securing this ETD with the plaster,
Now we are witnessing the saturation, it's gradually improving.
Okay. Is an RN support going on? Okay, fluids on another line. Okay. Rush the fluid. And ask the
Is the
patient.
patient okay, sir? Shall we shift the patient
Wait,
to OT?
have you done any all other investigations, blood samples and
Yes, sir.
reserved?
Investigation are taken, sir.
Okay, I need emergency 1 PRBC at least and 4
Okay,
FFP
sir, I have
also.
informed blood bank.
Okay.
I have
I
given
need-
cross-matched plate.
What is the pre-op HB?
Pre-op HP was 11 grams.
Okay. Right now I need 1 PRBC. If needed, I need more 2 PRBC and also 4 FFP.
Okay, sir.
Okay. Just immediately shift the patient to OT. We can take the procedure.
Anybody please reserve 4 units FOP and 3 units PRBC in the blood bank.
For the time being, patient saturation has improved and we have settled the vitals and the hemodynamics with inotropes. But still patient is
Sir, the patient is bleeding, so we are now planning to shift the patient to operation theatre with the help of NASG suit. Now we are going to apply the non-pneumatic anti-shock garment to the patient.
This garment will work only if the patient before going for an irreversible shock. Once the patient has gone for irreversible shock, this garment will have no role to play. So you have to apply it as early as possible.
So the garment has 6 segments. Okay, the first segment is just above the ankles and 2 has to be.
In the meantime, I'm getting ready inside the OT theater with all the drugs, any other inotropes support, infusion pumps and infusers, and all other blood arrangements, and any other emergency RN DOPA and all other inotropes support. I'm getting ready inside the OT theater.
Both segments should be applied simultaneously with an assistant. Now I am applying segment 1. Kanimuri, please apply segment 1. Now the second segment should be applied over the cough muscles. Segment 2, and the third segment just above the knee, have to leave the knee. Putting the patient in lithotomy position. That is the advantage of this garment. And the fourth segment should be applied over the pubic symphysis. The fifth segment has a ball over it. It will massage the uterus, and over that ball we have to apply the sixth segment. Now we are shifting the patient to OT.
While shifting the patient, we should handle the patient very carefully. Also, because ETDM is inside, it should not come out. So you should carefully shift the patient. Okay. I have connected all the monitors, BP apparatus, saturation probe, and ECG, and also seeing his vitals. And right now, the saturation got improved. So, and vitals also little improved, 90-60. So, I'm asking the surgeon to start the case.
Now the time is 2:50 p.m. So for doing surgery, we have to remove the segment 5 and 6. Okay, and segment 4.
Meanwhile, we have transfused 2 PRB6 and blood has been kept for preservation and it's on the way.
Now, first we are going on to do compression manuals, conservative surgical procedures. We have compression techniques and devascularization techniques. Okay.
But the surgical procedure is going on. I am getting ready to cannulate a right IJV under ultrasound guidance. Okay.
The patient is in general anesthesia now. Now I am going to paint and drape. Now I am putting suprapubic transverse incision and abdomen is open in layers. Now since the patient has delivered vaginally, we are actually going for Hayman suturing. The P-Lynch compression sutures should have an open hysterotomy wound. For a patient who has delivered normally, you have to go for the modification of P-Lynch sutures, that is Hayman suturing. So with an assistant, now I am going to demonstrate how to put an Hayman suture. Okay. Now this is the uterus. This is the lower uterine segment. So below the lower uterine segment, 2 cm medial to the lateral border, and in the lower uterine segment, we have to go from anterior to posterior. It is slide over the uterus.
How much the loss, ma'am? Should we activate the MTP?
Yes, sir.
See, once the bleeding is not getting controlled and the vitals is not being stabilized, then we have to activate the massive blood transfusion protocol.
Now another suture is placed on the opposite side from the anterior to posterior. You have to make sure that you are not injuring bowel posterior. Okay.
Meanwhile, I secured this right IJV under ultrasound guidance and started inodrop support through central venous.
Now I'll ask my assistant to compress the uterus. So the compression suture has been applied, but the uterus is still flabby. So do local examination, Dr. Reshma. iliac artery ligation. Okay, so the internal iliac artery ligation will convert the arterial system into the venous system, which enhance the clot formation. So 85% there will be reduction in the arterial pressure. So the bleeding will get arrested by at least 98%. Okay, the efficacy is low compared to uterine artery ligation. The uterine artery ligation will stop the postpartum hemorrhage by 80 to 85%. The internal iliac artery will do it by 90%. Okay, so now the internal iliac artery ligation has been done. Sir, patient vital, sir.
How much is the blood loss now?
Blood loss will be 1.5 liters.
Okay, only 2 PRBCs only transfused now. I need one more PRBC now and also 4 FFB. So we are continuing this massive transfusion protocol.
The patient has bled more, so we are going on to massive blood transfusion protocol.
And iron drop support was given through the central venous catheter. Okay?
So, stepwise devascularization has not helped much. The uterus is still flabby and the patient is bleeding so much. So, we are moving on to the last line of management, non-conservative surgical management, that is peripartum hysterectomy. Okay, now we are proceeding with peripartum hysterectomy to save the patient.
As we are proceeding with this massive transfusion protocol, the patient may undergo trolley, that is transfusion related acute lung injury or sometimes pulmonary edema. So I am giving just 1 cc of Lasix now initially after auscultation. And also monitoring this. Take the blood sample and ABG and take thromboelastogram.
So we are using 3 clamps for completing peripartum hysterectomy. It should be so faster. We should not delay. So we have to give first clamp over the round ligament, tubo-ovarian ligament. The round ligament and the tubo-ovarian ligament should be clamped together. This is the first clamp, and we have to go down to clamp the uterine artery. That is uterine vessels, uterine artery and vein. This is the second clamp, and the third clamp will be at the level of transverse cervical ligament and uterosacral ligament. Okay, now the clamping has been done. The clamped, cut and ligated. All ligatures were tight. We have to ensure that all ligatures are tight and the uterus is removed safe. Now, sir, what is the vitals of the patient, sir? Hysterectomy has been completed.
Okay, what a BP is 100 and
There is no
161.
bleed from the wall.
Pulse volume 118 and saturation is just now 96. What is the urine output? It's not normal. Okay. Third PRB is also rushed and now it is FFP is on flow and inotrop support on flow through the central venous catheter. Okay, just give 5 ampules of bicarbonate and 1 ampule of calcium carbonate also.
Okay, sir, there is no bleed from the wall and the pedicles are good. There is no bleeding from the vessel pedicle.
Vitals okay, ma'am. As of now, it is okay.
Shall I close the abdomen?
Yeah, you can close. Proceed.
Now I am closing after completely checking the hemostasis, I am closing the abdomen by layers. Okay, sterile dressing has been done. Now after checking the vitals, we are planning to shift the patient to ICU, intensive care unit.
In view of more blood loss and also this emergency situations, these obstetric cases, we are planning to shift the patient to ICU for elective ventilations, observe the patient for at least 24 hours, vitals monitoring, urine output, and also the chest clearance, and also any other pulse volume and everything we should monitor. After that, stabilizing this, also we should do the ABG and thromboelastogram. If everything becomes normal, we can plan for weaning and also extubation. For at least 24 hours, we have to do this elective ventilations, ma'am. So we are now going to shift the patient to ICU.
Now the time is 3:20 p.m. The patient has delivered at 2 p.m. Now the procedure has been completed at 3:20 p.m. Now the patient is stable. We are planning to shift the patient to ICU for elective ventilation. Okay. Now the patient is in ICU now. Dr. Yureshma, check the vitals and inform. The patient has been connected to mechanical ventilator.
Okay, patient is on mechanical ventilation.
Ma'am, the BP is 110/70 and the pulse is 100, ma'am.
The demonstration is over. Actually, we have to quickly, the prompt identification of PPH and identifying the cause of PPH and prompt management based on the cause of PPH will help us to save the patient in time. Okay. From NASG suit from segment 1 to segment 6. Like that, you have to remove the NASG suit from segment 1 to segment 6. You have to remove the segment 1 first. You have to check the vitals. If the BP reduces by 20, systolic blood pressure reduces by 20 and the pulse rate increases by 20, you have to reapply the segment again. If the vitals are maintaining, you have to go on removing the segment 2. After removing the segment 2, if the BP falls and the pulse rate rises, you have to again apply the segment 2. The vitals are maintaining, we can safely remove the NASG suit every 15 minutes. Each segment every 15 minutes. Thank you.